Good evening, one and all. This is Shagnik, the designated moderator from ClearNet for this session. ClearNet is very proud to be a part of this webinar as its digital partner. Now, before we move forward, I would like to share a small video of ClearNet. I hope my screen is visible. Thank you all for your kind patience. As we all know, ClearNet is India's largest live digital CMI and doctors generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clearnet.com, where you can watch lots of live sessions conducted by doctors with great expertise all across the globe. We also have MedWiki service, which is a medical Wikipedia, which is exclusive for the doctors to read as well. We are very grateful to this association and this star-studded panel with such highly affiliated doctors to be associated with us on our platform. Before we start, I'll request everyone to keep themselves muted apart from the person giving the presentation or who has the virtual stage for smoother audio streaming. Also, if any faculty member has the virtual stage and they're speaking on our platform, I'll request them to keep their video on as well. If you have any questions, you can put it in the chat box. I'll be here till the end of the session. Now, I would like to call upon the MOC for today's session, Dr. Priya Shinde ma'am. Dr. Priya Shinde ma'am needs actually very little to no introduction, but she's a consultant obstetrician and gynecologist at Hospital Bhadravati, Chandrapur. Ma'am, if you may please take the virtual stage.
Thank you. Thank you, Mr. Sagnik. Okay, Namaste and greetings from Pole City, Chandrapur. Welcome aboard. I am your host today, and I extend my warm welcome to one and all. At the outset, I want to thank Dr. Monica Umbadan Madam and Dr. Komal Chavan Madam for giving me this opportunity to host this session, which is very informative and interactive, which is on strategies in family planning, organized by AMOX Family Welfare and MTP Committee and Public Awareness Committee, along with FPI and PAC Foxy. We are privileged to have with us respected guests from Foxy and AMOX. We have star speakers with us, chairpersons and delegates from the societies of Solapur, Akluj, Pandharpur, Islampur, Kolhapur, Miraj, and Satara. As per tradition, we wish to welcome our guest, respected Dr. Nandita Palshetkar Madam, Dr. Parag Biniwale Sir, conveners of the program, President FPI, Dr. Desai Madam, all chairpersons to join for virtual inauguration and lamp lighting. Please share the video. Mr. Sagnik. Thank you very much. I would like to invite and introduce convener of the program, Dr. Komal Chavan Madam. Her CV, please. We all know Komal Chavan Madam. Madam is contesting for the post of VP. All the best, Madam. She is a director, Chavan Maternity and Nursing Home. She is a senior consultant, DNB teacher. Thank you. And unit chief at VN Desai Hospital, Mumbai. Madam at present is the chairperson of the AMOX Family Welfare and MTP Committee. She is a zonal coordinator of the Foxy, and she was the chairperson Foxy Medical Disorder in Pregnancy Committee. Madam has so many awards to her credit. I welcome you, ma'am, and over to you for further proceedings.
Thank you so much, Priya, for the kind introduction. and I bring greetings from the AMOX Family Welfare and MTP Committee. And we have been always planning to do some programs with the Family Planning Association of India. And I really thank AMOX, Dr. Pardesi sir, Dr. Sujata Darvi, and Dr. Desai from FPAI for collaboration. And this is something which we really want to do more in family planning, as we know that India is now becoming almost the second, and we are expecting it to become the most populated country soon. And family planning is something which is a need of the hour. And we all should join hand together and work on strategies and improve our practices for family planning. That is the highlight of the program. And I'm really blessed to have luminaries for this program. I have chief guest Dr. Nandita Palchetkar. I've been so fortunate that she has joined in spite of her busy schedule. She has just landed from a flight and she's waiting at the airport. So I would like to welcome her first. And may I have Madam's slide CV before I tell her to speak few words? Uh, Support, ClearNet?
Yes, ma'am.
Yeah.
Komal, you don't need a big introduction. You can just do it short,
Yeah,
in short.
I know, Nandita madam. We all know. Actually, she is an icon in OBGYN. That's what I can tell about her. And she has been the president of Foxy in 2019. I have worked with her as a chairperson when I was a chair of medical disorders in pregnancy committee. She is an honorary recipient of the FRCOG from the Royal College, professor of OBGYN at DY Patil Medical College, a teacher par excellence. I think a doctor, very humble. You know, I think we all look up to her. That is what we admire her, and she is an inspiration for so many. So over to you, Dr. Nandita madam. You can please address the gathering. Thank you so much.
Thank you, Komal. Thank you for those kind words. And it's always a pleasure to come back to the Amox family to address them. And I'm so proud of you. You've been working so hard. I've seen you grow up and come to maturity, and I'm so glad to see you do different things, and you've achieved so much. And all the best for your future endeavors. I think that's amazing. Uh, I think you'll make a wonderful, wonderful person in Foxy. You'll contribute a lot. To come to today's seminar, I think family planning is a very, very important part of our, you know, care that we deliver to the women of our country. And as Komal just said, that we will probably become the most populous country in the world. So the best part about family planning is that with the efforts of everybody, I think the fertility rates, as the NHS shows, have stabilized. And in fact, they are below 2 in a lot of places. So I think we are somewhere coming to a control. And I'm so happy Dr. Desai is here, because I remember in my year, we started this association with Family Planning Association of India. And it's always better and always, very good to work with associations, because your work is always amplified. I think somebody who's so focused and targeted, like the Family Planning Association, and to work with the Welfare Committee of EMOGS is fantastic. So newer contraceptives, Foxy is now going to start training everybody for implanon insertion removal techniques. So a lot of new things in the basket, and I'm sure you're going to discuss it today. And it's a very exciting time for family planning era at this point, because there are many new things on the horizon. So I wish you all the best. I think you'll have a wonderful, wonderful discussion. And Dr. Pardesi, I think I'm really proud of how the Amox flag is flying under his leadership. And it's fantastic. And it's nice to have Parag Benewale, who is my dear friend and president of POGS, here with me today as a guest of honor. So thank you, Komal, for inviting me. Unfortunately, I have to, sign out, because I have to leave the airport and the signal might go. But thank you very much for inviting me here, and all the best.
Thank you so much for those inspiring words, madam. And we are really honored to that you have joined the program. And now, can I have the slide CV? I'll introduce Dr. Madhuri Patel, the Secretary General of Foxy. I can't see Madhuri Patel madam's video.
They have, Komal, they have switched off my video. I've written to them on the chat box.
Can the team switch
One
on
second,
Dr.
ma'am. One second, ma'am. I'm looking forward to
Can
it.
I have
Madhuri,
Dr.
ma'am,
Madhuri
right?
Patel's slide? Yes.
Yes, ma'am. I'm giving the slide as well. Wait. Ma'am, I have sent you a request to start your video. You should be able to join it.
Yes.
Okay, okay.
Yeah.
Yes, yes.
So we all know Dr. Madhuri Patel. She is a Secretary General of FOXI. She's the she is the first lady Secretary General of FOXI. She has also a joint associate editor of the Journal of Obstetrics and Gynecology of India, honorary clinical associate at Nauroji Wadia Hospital, Parel, and also a consultant at Police Hospital, Elizabeth Messina, and she has been the professor of an HOD of OBGYN at ESIS Hospital and has been the chairperson of Breast Committee FOXI. And we all know Dr. Madhuri Patel as a very, very dynamic Secretary General and really very taking a lot of decisions and so much work on our shoulders. We have been closely working. Yesterday we were at the Republic Day function, and it is always honor that Madam is always there for all the functions of FOXI. So we really feel very glad and motivated to do more and more. Welcome, Madam, and we would like you to address the gathering.
Thank you, Komal, for your very warm and generous words. Respected our President, Dr. Rishikesh Pai, then our AMOC's President, Dr. Rajendra Singh Pardesi, with whom I have worked when he was Vice President, and now also we are working in FOXI together because AMOCs and FOXI, they go hand in hand. And this time, they have asked for the Maharashtra government has asked for the guidelines for cesarean section. So we are working together with Rajendra Singh and FOXI office and AMOG's office. Then, of course, we have today's chief guest. We have Dr. Nandita Parshikar, my dear friend. Then Dr. Guest of honor, Dr. Parag, who is also my dear friends, and we have worked in FOXI together for many years. Then today's, FPA Chief, President Dr. Ratnamala Desai. Then, of course, we have Dr. Bipin Pandit, Sujata, Amaya, Rohan, then Kiran. Kiran, I cannot forget. Kiran is also, we have worked together in FOXI. Ajay, Rohan, and our co-conveners are Komal, Monica, and Priyanku. And of course, Dr. Priya Shinde from Chandrapur, she is a MOC. Then all my dear friends, in case I've forgotten somebody, please, forgive me. And all the speakers, experts, chairpersons, moderators, and panelists, and all my dear friends today who have joined for this webinar. Very good evening to all of you. At the outset, I would like to thank, organizer for giving me this opportunity. I will not say much, but I will only say that FOXI and AMOX are working together, and we are, working towards the women's health. And I was in Delhi, and we have realized that the reduction of maternal mortality rate has to be, where it should be come drastically down in our nation. But as far as Maharashtra is concerned, I will say that 3 decades back, our national maternal mortality rate was 600 per 100,000 live birth. And today we are at 97 per 100,000 live birth. So that is very commendable job our nation has done. And this is all because of all the schemes like, National Rural Health Mission, JSK, JSSI, Prime Minister Surakshit Matruya Abhiyan. Then, now we have a Prime Minister, that is Ayushman Bharat, then Suman. All these, schemes, plus our people who are at the grassroots level worker, they are doing excellent job. And I'm really, really congratulating our, members that because of them, because of the government, we could reduce the maternal mortality rate to 97 per 100,000 live birth. And, I was there in Delhi 2 weeks back with all the stakeholders, and what we found that Maharashtra, Dr. Deshpande from Health Services presented the report, and Maharashtra maternal mortality rate has reduced to 33, per 100,000 live birth. So it is really, really, we have to, really, it's really, I must congratulate all of us, the Maharashtrian, obstetrician, that we could achieve 33 per 100,000 live birth. So that is remarkable. And therefore, what he mentioned, that the 99% in Maharashtra, the deliveries are occurring in institution. Then there are specialists are available, and of course they have also improved the infrastructure. And one more, he has said, then Manyata, our Foxy Manyata Lakshya program is doing very well along with Maharashtra government. So our Manyata Foxy's flagship program into the private sector, because whatever scheme comes, they are all for the public sector. But the private sector, we don't get any scheme. So our Manyata is a flagship program of the Foxy, where we are looking after the private sector. We are training not only the obstetrician, but also the paramedical staff of the facilities. And that has really reduced the maternal mortality rate. So I, believe that we should, work together and do the justice to our women, and they should have a quality of life. And therefore, it will help not only the family, society, and the nation. So I thank all of you for inviting me as during this for this webinar. Thank you once again, Rajendra. Thank you once again, and Rishikesh. Thank you once again, all the organizers.
Thank you so much, Madhuri Madam, for those kind words. And definitely, we obstetricians are striving our best, and with our efforts, we are seeing results also. But we still have to work more, and our joint efforts will take us where we want, will make us achieve our goals. So I am really so thankful for this webinar, and this has been always the support of Dr. Pardesi sir, who has always been so inspiring. And AMOX, we are participating with so many societies, that is Solapur, Akluj, Pandarpur, Islampur, Kolhapur, Meerut, Satara. So all the societies and their president and secretaries, I'm so thankful for joining in this webinar. And now I hand over to my co-convener, Dr. Monica, to do the further proceedings.
Thank you, Dr. Komal
Monica,
Chauhan,
you're
madam. Madam, I will introduce you first.
Yes, you can introduce.
No introduction here.
Monica is very dynamic. I can just tell lines about her. She's very dynamic, very prompt, and very enthusiastic. So, and she's the chair of Public Awareness Committee of AMOX. So, over to you.
Thank you so much, ma'am. Not taking much of the time, I would first like to thank Foxy Public Awareness Committee, AMOX MTP and Family Welfare Committee for associating with AMOX Public Awareness Committee, along with Family Planning Association. It is so very crucial that we all join hands for a noble cause, for the upliftment of the women of our country. I take the honor and privilege to introduce Dr. Pardesi, sir. He is the president among.
It's okay, Monica. Good evening, everybody. Respected chief guest, Dr. Nandita Palsetkar.
President that I have seen at AMOX, the most approachable person. He never says no for any program, ma'am.
It's okay.
We welcome you, sir, and ask you for the blessings of this program.
Good evening, everybody. Respected chief guest, Dr. Nandita Palsetkar, our Iron Lady of AMOX. Then guest of honor, Dr. Parag Biniwale, Dr. Rishikesh Pai, and our mother figure, Dr. Madhuri Patel, and my AMOX team. First, I wish to congratulate Dr. Komal Chauhan, Dr. Monica, and Dr. Priyankur for this such a practical webinar on contraception and MTP. I wish to congratulate Dr. Komal Chauhan, our ever-active chairperson of AMOX and MTP and Family Welfare Committee, for taking pains to organize this. I congratulate our societies, active societies, Solapur, Akluj, Pandarpur, Islampur, Kolhapur, Meerut, Satara Society, for their active participation. Just I wish to add to biodata of Dr. Komal Chauhan, Dr. Madhuri Madam, and all. She's collecting data of LSCS from all our societies, and she's taking pains for this data, because we have to give answer to government that why cesarean section rate has been increased in Maharashtra. It has been increased up to 39%. But our contention is that we have to tell them that maternal mortality rate has been gone down, and even neonatal mortality rate has been gone down to from 46 to 19. So this data she is collecting, Dr. Komal Chauhan. So please cooperate her for the data, so that we can answer ethically and rightly to government. I wish every success to Dr. Komal Chavan for her future endeavor in Foxy. I don't want to be in between you and scientific content. Wishing every success to this webinar. Thank you. Thank you so much. Monica, thank you.
Thank you so much for your words of blessings. We now invite Dr. Parag Beniwale, sir. Can we have please? Sir is a senior consultant obstetrician and gynecologist at Pune. He is also the KG teacher and unit head at Karnataka Nehru Hospital. He is currently the president of Pune OBGYN Society and the chairperson of ICOG 21-23. He is also the president of Menopause Society Pune.
Thank you, Monica. Monica, thank you very much.
We welcome you, sir, and please bless this webinar.
Sure. Thank you. Good evening. I bring greetings from ICOG. It's indeed a pleasure to be present as a guest of honor, and at the same time, it sounds very funny because I am very much part of the AMOX, and being a guest of honor in an AMOX program is something different. So thank you, Komal and Monica, for the invitation. It's a pleasure to share the dais with very dear friends, Dr. Madhuri Patel and Dr. Rajendra Singh Pardesi. For me personally, family welfare has been an exciting area. I became member of the Family Welfare Committee of Foxy way back in the year 2000, and then I continued to be associated with the committee as a member and then as an advisor. Komal, I must compliment you for roping in Dr. Ratnamala Desai and the Family Planning Association of India, because when we have a body which is working exclusively in this field on board, I think the program is complete. And the messages that we give to the delegates are really useful. So once again, thank you very much for the invitation. My best wishes for the program and happy learning to all.
Thank you so much, sir. We are honored to have you with us. I would now hand over the session to Dr. Priya Shinde, madam, to please carry forward the session.
Yes. Thank you very much, respected seniors and all. Now it's time for the scientific session. Our first topic is newer contraceptive methods. As we all know, era has changed and era of newer contraceptions are there. To get acquainted with all the new such methods, we are fortunate to have with us speaker who is the president of FPI, and we will proceed to the first session. Please share the slide of the chairman, CVs. We have two chairpersons for the session. Please give me this. Yeah. I would like to invite Anjali Jamma. She is the president Solapur OBGYN Society and consultant at Jamma Hospital and Laparoscopy Surgery Center. She is the first laser gynec center in Solapur and nearby district, and her area of interest is in cosmetic gynecology. I welcome you, Anjali. Next, please. Our next chairperson is Dr. Nirupama Sagdev. She is the president of Kolhapur OBGYN Society. She is practicing gynecologist in Kolhapur, and her area of interest is in high-risk obstetrics. I welcome you, Dr. Nirupama ma'am. And I now hand over the proceedings to chairperson for further to invite our speaker.
Good evening, one and all. Thank you, PAC committee, Foxy and Amos, for especially Monica, for giving this opportunity for this most needed topic. We have today a great orator, Dr. Ratnamala Desai. She is a president, FPA India, and is a principal of college, SDM College of Medical Sciences, Dharwad. She is working as a professor in the Department of OBGYN SDM College, and she is honored as a country coordinator, Geneva Foundation of Medical Education. She has worked as an expert member of a comprehensive abortion care and a technical resource group for Ministry of Health and Family Welfare, Government of India. She will enlighten us on newer contraceptive methods which is most needed topic for today. Over to you, madam.
Thank you. I will just share my slides. Okay. Okay, good evening, friends. I deem it an honor to be invited by AMOGS for this talk on newer contraceptives, and I bring greetings to you from FPI India. I hope I'm audible. Am I audible?
Yes,
Yes,
madam.
ma'am.
Yes,
Yes,
ma'am.
ma'am.
Yeah, thank you so much. So I bring greetings to you from FPI India, and today we are going to talk about newer contraceptive methods. Now, there is no ideal contraceptive. The quest is on for an ideal contraceptive, and we have tried different modes of contraceptive methods, like different types. Maybe it be hormones, may it be mechanical methods, or may it be different routes of administration, different delivery systems. So the search is on for a perfect or an ideal contraceptive, and we have none. So we have to use different methods to suit different people. So one size does not fit all. However, we have a diaphragm which fits all. So the first slide I show you here is what is called SILS, which is a diaphragm, which is a non-hormonal method, which is a barrier method. And as you know, the senior gynecologists will remember that different sizes of diaphragms were available to fit different size of people. And the woman would have to come to the clinic to get the correct size of the diaphragm. But this diaphragm is a single size, and it simplifies supply and provision, and it can be reused for 2 years. It fits most women, and pelvic examination is not required to determine the size. And the clinical effectiveness is similar to the traditional diaphragm, just like the male condom, like any other Mandy barrier method or a physical method. Now, multi-purpose prevention technology, when used with effective microbicide gel, it may be more effective in preventing even STIs. So this is one of the newer type of barrier methods, which is approved in USA. Now, to start with, I will talk about the newer methods which have been approved in the West, but not still approved in our country and not used in our country. So the next method is the extended cycle contraceptives. Now, we know that traditionally we use oral contraceptive pills for 21 days, and a woman would have a cycle every 28 days, she would have a cycle. Now, come to think of it, why should a woman have menstruation every month? There is no need for her to have menstruation every month. So somebody said it's so old-fashioned to have menstruation every month. So now we have an extended cycle of contraceptives called seasonal, where a woman would have 4 cycles per year, that is for 4 seasons, where she takes 3 months continuously, 4 packs of oral contraceptive pills, and then gives a break and has a withdrawal bleeding, and again takes for the next 4 months. Then Seasonic is also an oral contraceptive pill for extended use. And Liberal is really liberating a woman from having any menstrual cycle, where she takes these tablets for 1 year extended use. So seasonal and Seasonic are same, except that in Seasonic, in the 13th week, the ethinyl estradiol is in a lower dose of 10 micrograms, where it will reduce the withdrawal symptoms and migraines and dysmenorrhea, and it may cause less breakthrough bleeding. And Liberal is taken continuously for 365 days. So it contains 20 micrograms of ethinyl estradiol and LNG 0.9 milligrams. It's a 28 pill pack which she takes continuously. It is FDA approved. What is the advantage of a woman taking oral contraceptive pills continuously without a break for 365 days? She will not have any menstrual bleeding during the 13 pill pack, and 59% of them will have amenorrhea, 20% of them will have spotting only, and 21% would require some sanitary protection due to breakthrough bleeding. So these are the changes which are brought about in the oral contraceptive pills. Now, there are also newer delivery systems like the newer injectables, new types of implants, new types of vaginal rings, new patches, and a little change in the hormonal releasing IUCDs. So let's look at newer injectables. This is called Cynapress, which is used subcutaneously. Medroxyprogesterone acetate used subcutaneously. It's a long-acting reversible contraceptive. And talking of long-acting reversible contraceptives, I think it's time that we all think of long-acting reversible contraceptives rather than permanent methods, because we are promoting small families. And our women marry young and have 1 or 2 children even before they are 25. So it's always better to promote long-acting reversible contraceptives so that if they want fertility again, it would be advantageous to use a long-acting reversible contraceptive. So Cynapress, it contains 104 milligrams of medroxyprogesterone acetate in a 0.65 ml suspension, and it provides contraception just like DMPA for 13 weeks. It's available in a pre-filled, single-use, non-reusable Uniject injection system. It's approved for self-administration in Europe, and that should also come soon in the Indian market, where a woman can use this as a self-administration subcutaneous injection, where she need not come to the hospital even to get an injection, and she administers herself. Since WHO is also promoting this self-administered subcutaneous medroxyprogesterone acetate once in 3 months. Now we have the Implanon NXT. The Implanon NXT is a subdermal single rod implant. It's a long-acting, again, it's a long-acting reversible contraceptive effective for 3 years. And it contains progestogen only in a pre-loaded disposable applicator. Implanon NXT is the one which is now available. It is radio opaque. It is similar to the earlier Implanon, but the new one is called Implanon NXT. It is impregnated with barium sulfate, and the progestogen is etinogestrel implant. It's a 4 centimeter rod, 2 millimeters wide, and it contains a core of ethylene vinyl acetate copolymer impregnated, as I mentioned, with barium sulfate. And it contains 68 milligrams of a synthetic progesterone called etinogestrel. And it is safe and effective. It is suitable for almost all women of all ages. And it's particularly useful even in the postpartum period because it does not suppress breastfeeding, it does not suppress lactation. It's also useful in post-abortal and post-menstrual women. So it can be inserted soon after delivery, soon after an abortion, or soon after menses. The only problem is irregular bleeding pattern, and it may be a little problematic for some women. And the problem is a trained healthcare professional is required for insertion and removal. Here, I would like to tell you that Family Planning Association of India has already inserted 250 implants, and we have been successful in doing so in many of our centers, and we find that it is very effective. And so far, we have had very little no adverse effects and also very little complaints from the clients, and majority of the clients are satisfied with the Implanon NXT. And the government of India is likely to introduce Implanon NXT in the public sector shortly. We all know that there was a vaginal ring called the NUA ring, which contained ethinyl estradiol 15 micrograms and etinogestrel 120 micrograms. But there's a newer vaginal ring, which is called Anovera, which contains segestrone acetate and ethinyl estradiol, and which is approved by FDA in 2018. And clients can use the same ring every month for a year, wearing the ring for 3 weeks and on for 3 weeks and off for 1 week. And this can be repeated for 13 cycles. She can use it for 1 year. The advantage of this Anovera, the newer ring, is that it does not require refrigeration, and the ring is thicker than the current ring on the market, and it has demonstrated 97.3% efficacy in preventing pregnancy. So in the vaginal ring itself, this is a newer type of a vaginal ring. Then transdermal contraceptive system, we know that Ortho-Avera was already available in India. It's a transdermal patch which contains 6 milligrams of norelgestromin, and 0.75 milligrams of ethinyl estradiol. Now, Twirla is a new type of transdermal patch which contains LNG, levonorgestrel, and ethinyl estradiol. So it is a one patch per week for 3 weeks. Again, 3 weeks on and 1 week off. But it contains a lower dose of estrogen. So the total dose of the steroid the woman is going to consume is less. It contains about 30 micrograms of ethinyl estradiol compared to the earlier one, which contained 35 micrograms of ethinyl estradiol. And the progestogen here is levonorgestrel. Now, we also know that Mirena or LNG IUS was approved for 5 years earlier, and now the FDA has approved it for contraception for 7 years. Now, this is another FDA approved contraceptive, which is called Phexi. It is a non-hormonal contraceptive which contains lactic acid, citric acid, and potassium bicarbonate. It is supposed to be a vaginal pH modulator gel, which should be used within an hour before the sexual intercourse. So the woman should have used this gel within an hour before sexual intercourse, and it is shown to have 86% efficacy with typical use as much as a condom of typical use. So this is a non-hormonal contraceptive used as a vaginal gel where it modulates the vaginal pH. Then we have one more newer type of contraceptive called the Nextstellis. It is newly available contraceptive approved by FDA in April 2021, and it contains drospirenone, which many of our oral contraceptives do contain, and the estrogen is different here, which is called estetrol. Estetrol is being labeled as a native estrogen, naturally occurring, with selective action in tissues. That's why it is called NEST, because it is estrogen with selective action in tissues, and it has a half-life of 28 hours. And it also has a reduction of impact on hemostasis parameters and a minimal first-pass metabolism. So effectively, it is a better drug than ethinyl estradiol, and it is also currently being used for multiple uses in reproductive health, including a hormone replacement therapy and as in menopause. Then there is what is called SLIND. SLIND is drospirenone. It is a progesterone-only pill. We know that progesterone-only pills are already available. They contain desogestrel, norgestimate, or one of these progesterones. And this one contains drospirenone. And this is also approved by FDA in 2019. It works by suppression of ovulation, while the current norethindrone pill works by thickening the cervical mucus. Now, this pill is a 24/4 regimen, which means 24 tablets contain 4 milligrams of drospirenone and 4 tablets contain a placebo. And it has got a long half-life of 30 hours and showed to be longer acting progesterone than the norethindrone. So that is why missing a pill. Now we know that progestogen, we ask POP pills, we ask the woman to take it in the fixed window time every day. Now here, because it has got a long half-life, missing the pill, the ovulation suppression will still be maintained. Now these are, what I mentioned now, are already approved by FDA, but there are some which are also in the pipeline. Now, what are the newer types of contraceptives which are still in experimental phase? So Versep, it is an experimental hormone-free low-dose copper ICD, and it's still phase 3 trials are going on. And then there's another interesting non-hormonal contraceptive called OUI, which is a vaginal capsule that thickens the mucosa in the vagina. Of course, there are trials are not yet, the trials are on, but the data is not yet published. So now what about male contraception? So much happening in female contraception, but very little happening in male contraception. So in the male contraception, there is a gel and a pill. Two male contraceptives are in the pipeline, which could come into the market shortly. One is a gel consisting of progesterone and testosterone. This is to be rubbed onto the chest or the shoulders of the male partner, and it works by turning off the sperm production with progesterone and uses testosterone to counterbalance the loss of libido associated with the progesterone. So it's mainly the progesterone which acts as a contraceptive, and to sort of balance to counteract the adverse effects of progesterone where it causes loss of libido, testosterone is also supplemented. So it will counterbalance the loss of libido associated with progesterone. So phase 3 trials are still going on with this. The male pill is also available. A non-hormonal pill is being studied in the male mice, and they were given pill orally for 4 weeks. And this pill works by targeting the protein retinoic acid receptor alpha, so RAR alpha. And the study demonstrated a drastic reduction in sperm count in male mice and was 99% effective in preventing pregnancy with no observable side effects. And also the good thing was that the fertility was reversed in 4 to 6 hours. So many things are happening in the newer contraceptives, but as of now, the newest contraceptive which is going to be put into the basket of choices for Indian women would be the Implanon NXT. And with the little experience, we have found that clients are very happy, and we have already put 250 implants. So we are very excited about it, and we wish this will be soon available for all the women in our country who want a long-acting reversible contraceptive. Thank you very much for your patience.
Thank you, Dr. Desai, madam. Dr. Nirupama, madam, are you there?
Hello. Yes, yes, I'm there.
Yeah.
Yeah.
Over to you.
Yeah. So I will tell the chairpersons to conclude, or any questions or anything if they want to ask.
You are muted, Nirupama, madam. Please unmute yourself.
I think till she unmutes, I think it was a real insight on the newer methods. You know, we require this awareness among our practitioners and even training, so that there are so many patient-related queries, you know, how to use all these devices. And I think if we have some training modules or sessions for the gynecologist and obstetrician, like hands-on or something, then it will be more better. We can actually then use in practice, you know, these. And because the contraception is such that there is so much wide choices, and when once a patient, now they Google or something, so many choices are there, but we are really restricted to give very few methods, you know, which are there since so many years, which we are using. But I think your talk was really an eye-opening, and we now see that there are so many newer methods where we can try to our patients and we can give them benefit. And we would like to carry forward some training sessions for obstetrician also to Family Planning Association of India.
Can I say something? Can I say
Yes.
something?
Yes,
Implanon NXT requires a training of a day or two for insertion and removal, because it's a simple technique, but it has to be learned. So we have Family Planning Association of India has already done 2 training programs for insertion of Implanon NXT. It's a short 2-day program, but anyway, even though we are gynecologists and we are doing big surgeries like hysterectomy or radical hysterectomy or laparoscopic hysterectomy, even then Implanon insertion requires a little orientation and training, because one of the major complications of Implanon NXT is that it can migrate. If it is not put correctly subdermally in the correct place, it can migrate. And to date, there are about 38 cases where it has gone into the pulmonary artery. So the location and the insertion has to be done correctly. If done correctly, then these complications do not happen, and we are on to training gynecologists for insertion of Implanon. Thank you so much.
Hello, am I audible?
Yes.
Yes, it was really nice, Dr. Desai, to listen to you.
Thank you.
Like you said, you know, in Amox and Foxy, we keep on deliberating on so many surgeries and different things, but family planning has been the mainstay of our obstetric practice. And if to cut down the maternal mortality, we really have to focus on contraception and family planning. It was really wonderful insight into so many newer family planning methods, especially liberal and seasonal. I think we really can as a patient also would like to have lesser periods in a year than every month. So I think we are really looking forward to getting those newer methods in practice in India. And also, it was good to listen that there are a few more male contraceptive methods, because otherwise we keep on bothering our patients to control the family. But I think it's a responsibility should be together borne by the couple as such. It was really wonderful to have associated with this such a practical and very informative and for the future very important webinar. It was really nice to listen to Dr. Desai.
Thank you.
And I'm sure the AMOX and FOXY and Family Planning Association of India, if we can work together, it will really make the difference, because we are now most populous country. It has been proven. So we have much more work to do, I think, as a gynecologist. Thank you so much. Thank you, Monica. Thank you, Priya, for giving me this opportunity. And thank you from Kolhapur Obijaya Society.
Thank you. Thank you.
Thank you, Dr. Nirupama. I think you really spoke what we really wanted to highlight. And there is one question. There are so many questions actually which I have received. And there is one question. When Signa Press will be included in the Family Welfare Program of India? This is question by Dr. Anita Rajoria.
Well, that is a government policy, but as I know, shortly, Implanon and Synapres will come into the public basket shortly. Surely.
One more question. The questions are just flowing. There is one question by Dr. Ajay Shah. That is actually too much of pressurizing. So he's written that why not government indulge to strict family planning by giving incentive to non or a single child. So that is how he. I know it's very difficult in our country.
No, that's a policy decision to be taken by the government. And we have seen what happened in China when they took that very hard decision. We know what has happened. What are the repercussions? So let us not delve on that.
Yeah. And cost of each of these newer device, but Dr. Manorama has asked.
As I know, the cost of Implanon is about 3,000 rupees, but it lasts for 3 years.
Yes. So we have to see the effectiveness and the total cost, which will
it's
be
extremely, it's the most effective contraceptive today, 99.95%.
Wow.
And women would like to have a subdermal implant in their upper arm. They're happy rather than getting it in their uterus, copper T, and all the time wondering where it has migrated, whether it's gone into a lungs, whether it's got into a stomach, all those things.
Psychologically, it is little better for them.
Yes. It suits all women. It suits all women, all ages, and particularly for women who have had a past history of DVT. And even in those women in whom you can't use contraceptives which contain estrogen, you can use this. Yes, you are saying something.
Ma'am, can we request you to conduct the training online for all our AMOGs through public awareness committee members?
We will work on that, surely. Surely we'll work on that. Yes, we can correspond with each other and we'll work on that.
Yes, I think we really want to take this forward and we can have a continuation of the webinar and have some training when the trainings which have been already conducted. We just want something, an online, a complete training session only, where we can enlighten all our members. I think
enlighten all the map, then those who would be actually interested, we could give them some centers where they can actually go and see. The theory part we can take online.
And offline you can do hands-on. Hands-on is better. So we can think about that. No problem.
Yes, sure, ma'am. We will carry this forward, ma'am.
Yes, sure,
definitely.
Yeah.
Thank you so much, ma'am.
Thank you.
Dr. Priya,
yes,
can we conduct the...
I am completely in the coma. What I have heard, I am hearing for the first time. Thank you, Dr. Monica, madam, to bring me here as MOC, and I am listening to my full senses. All the names were new for me. I am listening for the first time, really. Thank you very much, Desai, madam. Thank you, chairpersons. Thank you very much. And thank you also, Monica, madam, and Komal, madam. Madam, is this available liberal and all?
No, liberal is not available as
Mm,
such,
not
but it
available.
just means that the same oral contraceptive pill, low dose oral contraceptive pill, you give it for 1 year. You give it 13 packs, you give her continuously without any withdrawal bleeding. You don't need a separate oral contraceptive pill for that. You give her the same low dose oral contraceptive pills for 13 packs. Of course, probably it comes in a separate pack, but in effect, if you want to give a woman extended use, the same pack you can give for 1 year, or the same pack you can give 4 packs, give her a break of 1 week, again 4 packs, give her a break of 1 week, again 4 packs and give her a break of 1 week. So every season she's going to have 1 period. That's all.
That's so nice to hear, madam. We gynecologists really need some training from you, because yeah, because we are,
But
when we learn,
from the mindset of the patient, is this really acceptable? Because where I am doing my practice, like in the taluka place, even for the injectable contraceptive after delivery, if the period doesn't come, the patient become anxious, and they want period every month.
I
Like
know,
the
I know.
mindset.
It is a
The
sign of
working woman.
femininity. Having
Mhm.
periods every month, some people think it's a sign of femininity. Why should a woman have periods, if you ask me? Why
But
should she
I-
have? And why should she lose that blood unnecessarily? If she
Mm.
wants to conceive, yes. And you know that you just need to explain to the patient that menstruation is when you fail to conceive, that spongy, nutritious vascular bed which was prepared to receive the zygote is being shed. That's all. Now, since you don't want a pregnancy, why do you want that bed to be created and shed? Isn't it? And someone told me in one conference that having menstruation monthly is such an old-fashioned 20th century thing. Why should they have?
Can I add, Komal?
Yes.
Yes, ma'am.
Yeah, the flight pilots and air hostesses
Yeah.
accepted this. When you have a leave, you come home and leave. And madam has, it was really a convincing talk, madam. Thank you,
Thank you so much.
It was
Thank
really
you.
good. They've accepted the fact.
Yeah.
So we have
No,
to.
Girls with
monthly
21-22 will really accept this.
monthly
This-
period is a nuisance if you ask me.
Ma'am, it
Correct.
is more problem with the mother-in-laws rather than the patient, because they
Yeah.
are more concerned with
And
the side effects.
one more, I have calculated 80 ml per month and counts to average of 35 so-called years. So it comes to around some 29 liters you bleed unnecessarily. And where the blood comes from, I don't know.
Yes.
It's like magical. So we have to convince in this way, like you are like bleeding, you are losing unnecessary blood.
True, true. That is why the incidence of anemia becomes less in women who
Less.
use implants.
True.
Because 50% of them, half of them either will have amenorrhea or less bleeding.
Sure. It would be more productive days if the number of days of periods are less. At least for career-oriented women, it would be more of a blessing, because they'll be more oriented towards that, and they'll be more productive during those days if they don't have that.
Yes, they're talking of giving PGs 2 days leave because of menstruation. I think we can avoid giving that.
Yes, definitely, ma'am.
I think soon we will get this study. How is the acceptance in the society with these tablets?
Yes. True.
Soon
Sure.
we'll get that studies from all of you. Okay, moving ahead. Our
Thank
next
you.
talk is post-abortal contraception. And our speaker was Dr. Mrinalini Mani, but madam is, because of some emergency, can't attend. So instead of them, Dr. Shamala Dupte madam will be the speaker. And our chairpersons are Dr. Priya Kadam and Dr. Monica Kuloli. So Dr. Priya Kadam, she is the director of Yashoda Hospital. She is the director of Vatsala Test Tube Baby Center, Akluj. And she is the president of Akluj OBGY Society. She is lead assessor for Laksha Manyata Foxy Initiative. I welcome you, Dr. Priya Kadam, madam. Dr. Monica Kuloli, please. CV. I was in the afternoon reading her CV, and it was like she has taken many trainings, ultrasound from Sayan Hospital, pelviscopy training in Kiel, University, Germany, obstetric and a sphincter trauma course at Fernandez Hospital. She is presently the president of Miraj OBGY Society. She has so many presentations and publications to her credit. I welcome Dr. Monica Puloli. And
Yeah,
over to you.
very good evening.
Good evening. Over to you.
Good evening, everyone. Hello.
Hello.
Am I audible?
Yes, yes, you are very much audible.
Yeah, so very good evening to you all. Today, I mean, as we are running short of time, I would just cut, the speaker has been changed, right?
Yeah. Shamla,
You will
please
be,
share the CV.
Yeah, please. Yeah, Dr. Shamla Dupte. She's a preventive and social medicine consultant from India, working from Family Planning Association since last 12 years in various capacities. Director Medical being the last one. She has been in the field of public health for over 22 years with focused work around health issues among women and children. At present, she is a full-time consultant with FPAI and provides technical assistance to clinical teams in 40 branches of FPAI spread across the country to improve quality of SRH, majorly abortion and family planning services. She has worked as a project director for one of the largest abortion service delivery projects, Global Comprehensive Abortion Care Initiative in India, supported by anonymous donor through International Planned Parenthood Federation. She presented her work on understanding women's experiences with self-induced abortion, IDIs with women in 3 FPII clinics in FIGO 2018 at Rio. So today we are going to listen from the expert, Dr. Shamla, regarding the post-abortive contraceptives. And for me, the real challenges here would be to how do we take care of expulsion and infection rate if we are using any devices. And let's listen to the expert, Dr. Shamla. Over to you, ma'am. Dr. Shamla? Hello? Hello?
Dr. Shamala ma'am's audio and video both are working. I have texted her once. I'm just seeing if she's responding or not. But Dr. Shamala ma'am is here in the meeting. Just checking once.
So we would, till ma'am joins, I think we would be interested in listening to and knowing what are all the newer modalities which are available for the post-abortion contraceptive options we have with us, and the challenges we face in acceptance of the same, because most of the time we come only MTP as a choice and not associate with contraceptive along with MTP is what the patients come up with, and how do we face it. So Dr. Shamla, she's come back.
The madam is there. I can see her video on.
Yes, I have texted her. I have text. Hello. I have texted her once. She is here.
We can see her.
Yes, I think everybody can see.
Shamla is here.
She's not audible.
I think you're not audible. The mic which you're talking, na, I think we can't hear
She
you.
should remove that and just be on the laptop.
We can see you, but we can't hear you.
No, ma'am, the audio is not coming.
I think she'll have to check the audio system from the
laptop, ma'am. You can start.
You can log into any other device as well. If you just click on the audio section at the bottom right of your computer, of your laptop, there's a volume button.
Hello.
Samna, can you please help ma'am? Just give her a call and give the instructions, no, please. Or madam can just join in again, leave and join
from another device. If she can join from another device, because if her laptop's audio is not working, she can join in from any other device and she can continue.
Ma'am, you can join in from your mobile and the laptop at the same time. Speak on your mobile and you can share the laptop screen also, ma'am.
No. We can hear the audio from the mobile.
Can you give her a call? Because
Hello, ma'am.
Can you hear us? Yes, so we can't hear actually. There is some audio problem then from your end. I think you will have to select that wherever that mic button is there. Just check your microphone and your speaker.
I am doing that.
We can hear you now.
Yes, ma'am.
We can hear you now.
Now?
Yes, we
Okay,
can.
so I think, yeah, it is. Oh, I don't need this then.
We can hear you.
Okay, fine. And extremely sorry. Now my video is not working, I guess.
Yes, ma'am. It has stopped a bit. Ma'am, you can do one thing. You can join in from another device. You can share your screen through your laptop, and you can talk on your mobile as well if there is a bandwidth problem. I think there's a bandwidth network problem.
Okay, fine. Can you all see the screen?
Yes, ma'am. Yes, ma'am. It's visible. If you can make it full screen once, yes, ma'am. Yes, ma'am. It's visible.
Yeah, we can hear you and we can see the screen.
Okay, fine. So probably the camera, or maybe I'm the odd one out. This is a gathering of all the gynecologists, and I'm the only PSM person here. So maybe on the lighter note, but good evening, everybody, and thank you for inviting FPA India. And it is a great honor to speak after Dr. Ratnamala Madam. And just to add, I think out of humility, she did not share, but she is a trainer for the implants going at full speed. My presentation all heard the expectations about some clinical aspects of post-abortion contraception, but it is majorly going to be about, let us go through the presentation. I heard that the time is short. And to begin with, I will talk a little bit about the organization, Family Planning Association of India. We are a non-governmental organization committed to sexual and reproductive health and rights in India. We work with full integrity, inclusiveness, passion, and excellence. And as you can see on the slide, we are celebrating 73rd year of our existence. We were founded in 1949 as a national voluntary organization. As I mentioned, you can see in the photograph, our first Prime Minister of India, along with our founding members, Lady Danavanti Ramarao and the other great people who were after reducing the maternal mortality, which was extremely high post-independence. Now it is 33 in Maharashtra, as the earlier speakers mentioned. But from where we began was very high, and that was one reason why family planning was brought into on the agenda. After 73 years of journey, where we are is we have expanded our area of work to other thematic areas like family planning, MCH, comprehensive abortion care, GBV, livelihood skilling, comprehensive sexuality education, and STI, RTIs, including infection. You can see in the middle of the slide, map of India, and the pink dots are where we are present. Our headquarters is in Mumbai, and we have almost pan-India presence. You can see from Jammu Kashmir to Trivandrum in south, and from Rajkot in the east to Nagaland in the west. Sorry, from Rajkot in the west to Nagaland in the east. And just to give you an idea about our reach and how we work, we have static clinics, about 39 of them. We also work very closely with Government of India through urban family welfare centers, satellite clinics, outreach units, community-based distributors, associated clinics are the doctors who are associated with us, maternity, private maternity homes. Many of you may be associated with us in many of the private gynecologists I'm saying about through our branches. And in total, we are providing our services through about 1,000 service delivery points, as we call them. And annually, we touch upon 4.6 million direct beneficiaries. We provide them with SRH services. And also to add, we are founding member association of International Planned Parenthood Federation. We work with a vision mission, but to cut short, I would like to bring your attention to one fact, very honorable, that association's commendable work was, Government of India issued a commemorative postal stamp in honor of FPI India in the 50th year of existence, that is in 1999. And in short, this is how our clinics look. We have a counseling workstation, consultation, gynecologist consultation. We have a full-fledged operation theater ward, and all our clinics have laboratory, as well as some of them have sonography facility. And the clinical services that are available in FPA India clinics are contraceptives, all types of contraceptives, and the new addition in our basket of choices is hormonal implants. We also provide safe abortion services, all methods, along with post-abortion care, including post-abortion contraception. Then management of common gynecological conditions, RTI, STI, HIV-related complaints, urological conditions. Then male SRH services is something that we separately deal with. Gender-based violence, counseling and referral, anti and postnatal care, infertility-related services, and pediatric care, including immunization, is broadly what we are providing through our clinics. And just since I'm a public health person, I like to give this broader perspective where we are as a country. Abortion scenario in India. In 2015, Lancet Guttmacher Institute, they conducted study in India, and they published it in 2015. And before that, no authentic abortion data was available in India. And the data that came out really shocked all of us, even people in the abortion fraternity, that 48.1 million pregnancies occur in India, out of which 23 million are unintended pregnancies. So on the right side, you can see a pie chart. 43% of births, just a second, pregnancies are planned births, whereas more than 50% of them are unplanned. 11% of them land up in unintended births. So nothing happens. Even if it is unplanned pregnancy, it takes form of a complete delivery and a life is born. 11%, and 33% are induced abortions, and 5% of them miscarriage from unintended pregnancies, and 9% are miscarriages from intended pregnancies. And there is a high unmet need for contraception, especially spacing. Couples use abortion. What we see is couples use abortion, safe or unsafe both, as a method to end unintended pregnancy. This is because of ignorance and lack of access to family planning services, especially post-abortion contraception. Abortion is a felt need by our community, but family planning is not. Medical abortion is legal only if it is offered by a trained doctor in a clinical setup, which is not known by our community. And as you can see in the graph adjacent, 81% of all the abortions that take place in India are medical abortions. But if you can see the green pie chart below, 91% of the medical abortions take place outside the facility, and 2% only take place in public health facilities, and 7% of them take place in private facilities. And out of surgical abortions, if you see the blue pie chart above, 25% go to public facilities, but 75% of these surgical abortions take place in private providers, that is private gynecologists, that is the practicing gynecologists like all of you. Women tend to avoid contact with healthcare providers and prefer anonymous over-the-counter abortion, but are deprived of post-abortion contraception and protection from yet another unintended pregnancy. So this is where we start. What is comprehensive abortion care? It is the components of comprehensive abortion care are pre-abortion counseling. So any abortion needs to have a pre-abortion counseling, and in that counseling session, information about types and procedure of abortion, legal aspects if necessary. Legal aspects may be necessary if the client is below 18 years or if the gestational age is beyond the gestational age limits permitted by the law. And post-abortion contraception need and method need to be explained to the client before she undergoes the abortion procedure. This is a deciding counseling session. So the course might completely change. What the client comes to you for and what she actually receives rightfully within the legal framework may be totally different. So this is a very important step. Of course, abortion procedure, post-abortion counseling, follow-up, and complication managements, if any. So what is a post-abortion contraception on family planning? Post-abortion family planning, by definition, it is initiation and use of family planning methods at the time of management of an abortion or before the fertility returns after abortion. And before the fertility returns is different for different methods of abortion. So return of fertility post-abortion, for first trimester abortion after surgical abortion, a woman may ovulate within 10 days of abortion. And you may, you are practicing gynecologists, you may have experienced this in your clinics. She can get pregnant as soon as she resumes the sexual intercourse without using any contraception. And after medical abortion, in the first trimester abortion, on an average, a woman will ovulate within 20 days of medical abortion with MIF and MISO combination, but can ovulate as early as 8 days. And as far as second trimester abortion goes, after medical abortion with, again, combination, within 4 weeks after second trimester abortion or miscarriage, a woman's fertility may return. So depending on this, what is advised is time of initiation of contraceptive method after abortion. For first trimester surgical abortions, you can see in the table that combined oral pills, progestin, POP, centromin, that is Chaya, injection DMPA, IUCD, can be started immediately after the abortion is completed. IUCD, of course, you have to check for infection or local injury to genital tract, and which needs to be ruled out or treated if it is there. As far as hormonal implants go, it can be started immediately, as even Madam mentioned in her slides. And female sterilization can be done immediately or within 7 days post-abortion, provided woman is eligible by. And it can be done by both methods, mini-lab as well as laparoscopic method. For first trimester after medical abortion, you can see that combined oral pills, POPs, centromin pills, they can be started on 3rd day or 15th day of medical abortion. 15th day is the follow-up day when the woman walks in, is called back in the clinic to check for completion and to check for any complications. Injection DMPA can be started on day 1 or 3rd day of medical abortion. IUCD can be inserted once the abortion is complete around 15th day and the presence of infection is ruled out. Implants can be inserted again on day 1 or day 3. Day 3 is the second dose, as we know. So woman comes on day 1 and 3rd day. So whenever she comes, it is advised that it can be inserted. And female sterilization can be performed after her first menstrual cycle returns. And after second trimester abortions, after DNE, you can see that the methods that can be given to her immediately are combined oral pills, progestin pills, centromin pills, and injection DMPA. IUCD, again, it can be inserted immediately when the infection and injury are ruled out, but this is not the same as after first trimester abortion. It is the postpartum IUCD insertion technique that needs to be used for the obvious reasons. I don't have to go in the details of that. And implants, again, can be inserted immediately. Female sterilization post second trimester abortion can be performed concurrently or within 7 days post-abortion. But the method advised is only mini-lab. Laparoscopic tubal occlusion or sterilization is contraindicated as there are chances of injury to fallopian tube or uterus since the tubes are edematous. there is also a possibility of slipping of the rings from the tubes leading to failures. This is the post-abortion family planning technical update published by Government of India Ministry of Health and Family Welfare, which gives all the details about the methods available. Of course, it does not have hormonal implant related information because this was published in 2016, but very much applicable to our current practice. Hormonal implants are available in the market at present, but not so much robustly they are being popularized. Even the Government of India is working, as Madam mentioned, shortly it will be introduced in the basket, and after that uptake will increase. A little bit about our abortion, our experience of post-abortion contraception and how women behave as far as the post-abortion contraception acceptance goes. So this was a 13-year long abortion project that we had implemented in FPI India clinics. About 20 clinics implemented this. Number of abortion clients served, as you can see, from 2008 to 2021. You can see that the number of abortion clients increased gradually. It decreased in the last phase because of, obviously, because of the COVID. But all in all, in 13 years, we were able to give abortion services to 226,000 plus women clients. Post-abortion counseling and contraception. So by default, all the women were given post-abortion counseling, and those who chose to accept at least one method, we have the data here in front of us. And you can see that despite of counseling, the acceptance doesn't really match. So all the women will not accept post-abortion contraception. So we need to give them accurate information about return of fertility and chances of next unintended pregnancy and the side effects of repeat abortion procedures on her health. And the post-abortion contraception trend in FPI India, you can see that the red line is the long-term or the permanent methods here in this slide. And the short terms are blue ones. And you can see that the acceptance for the long term is going down slowly and the short term is definitely increasing. Even Madam mentioned that our young clients, they do not really want to choose the permanent method, operations as they call, Stri Nasabandi. They really are going for opting for even 10 years IUCD 380A. And after what we have experienced after implants is, as Madam, again, I'm repeating what she has said, is between implants and copper T, the women are overwhelmingly accepting hormonal implants because maybe Indian women, they are shy, they don't want to open up in front of clinician. And this gives them that kind of dignified treatment from their perspective. So the key takeaways are that post-abortion contraception must be an integral part of abortion care. Most of the methods can be offered to client immediately. Trends of post-abortion contraception choices show an inclination towards long-acting reversible methods like IUDs and implants rather than permanent methods. And last but not the least, male partners of abortion clients must be encouraged to accept contraception. So this was my short presentation, although it was not a clinical clinician's presentation. I think this is a slightly different from what you usually are used to, the kind of presentations that the gynecologist gathering is used to. So if there are any questions, I will take them.
Chairperson, like to comment?
Yeah, Dr. Shamla, that was a wonderful review of the entire government initiatives which have been taken for the abortion care and the contraceptives. It's a wonderful insight because as both maternal mortality, abortion and family plannings are all the government programs. And it's very important that we private practitioners and also be an active part regarding the counseling sessions and everything. So for the complete preview of the methods available with us.
Yeah, I would like to just
Hello.
thank Dr. Shamla. Actually, this was today because Brinanini doctor had to go in the last minute, and she was so kind enough to take the talk. And what best can we ask from the organization that is the Family Planning Association of India, because they deal with so much data and they share about the acceptance also. You know, we talk about actually the family planning that these methods are available, but actually what is accepting and how the to know the trends of accepting helps us in counseling the patients. You know, when we are so much sometimes confused, we are saying that you have to take this method or that method, but we now need to know the clientele, the age group, and then accordingly we can emphasize on certain method, because acceptance of family planning is something which we all have to work on. So I think it was a real great talk, and Dr. Varsha has put in something. uh, you can ask Dr. Varsha. She has asked a question.
Yeah, practically looking, post-abortal contraception, I would like to ask that we have to confirm the post-abortion abortion is complete, one. And these are the practical questions. What exactly contraceptive we should advise? Because nowadays we don't give that cafeteria approach. What is exact good for the patient, we have to suggest. So I would like to ask Madam about exact contraception after MMA.
After MMA, you're asking? Sorry,
I think
as I
even
understand
the government supplies, Centroman and all are available as a government supplies, which are freely distributed to the patients. And I think this could be the best this thing, because I mean, all the government
Coming here.
authorities here, they keep coming like to us to distribute the Centroman what they have.
Well, as I understand the question, you mentioned that cafeteria approach is no longer available. I would like to differ on that. Cafeteria approach is very much there. And we have to, what is cafeteria approach? Basically, it is informing the client about all the methods available, informing to her about what method would be suitable to her, but the decision would be hers finally. So even if we say that your age is 25 years and 10 years of COPD is better for you instead of undergoing a female sterilization, if the client chooses female sterilization as her method of choice, then we really cannot force a method on her. So that is the cafeteria. She chooses. We support her decision making, but we are not decision makers for her. That is something that we refrain from, and that is the cafeteria. Like how we go in a cafeteria and they give us a menu card. So we have these menu card styled posters which are stuck on the walls in our clinic, in all possible walls, on all possible, wherever they're sitting, in the waiting area, near the waiting area, outside the consultant's room, the counselor's room, the lab technician's room, everywhere. So they are given information, and that's how they are able
Dr.
to choose.
Shamla question here.
Yes.
Dr. Shamla,
yes.
we have come across like the acceptance of IUCDs is very, very less. They are too skeptical to use it. And what are your experiences and what are the reasons, and how can we like improve upon our counseling and highlighting on the few benefits of the IUCDs of like one time and no tension later, like everyday pills issues. Like what are the problems you face in the government setup for this?
Similar, because
such a
it
wonderful
is the same.
device going wasted is
It is for women, that's not their concern, right? It is our concern that how much the device costs and what what all resources, consumable supplies are necessary for a doctor to insert a copper-T inside a woman's uterus. They are not bothered about that, obviously. For them, it is the husband's sexual pleasure disruption, interruption, and the risk of infection, the constant feeling of the thread inside, the constant fear of expulsion, whether it is there inside or not. So all these concerns are there. It is the same Indian women we are talking about. In our clinics also, the acceptance to IUCD is as compared to the other methods is low. When injectables came in, it was a promising substitute for the IUCD. The injectables have gradually, we can see that in our graphs, gradually acceptance is going up. Two things. One is it is, it is not a private method. You don't have to lie down in front of a clinician and open up. It is something that is woman controlled. And the other thing is it is short acting that way. So they can stop and then whenever they want a second jet. So for spacing, definitely injection DMPA has a better acceptance in our clinics than IUCD. IUCD, how do we position IUCD? We position IUCD against female sterilization, not against the other methods which are reversible long-acting. So instead of undergoing female sterilization, you can use 2 10 years IUCDs. So 20 years of contraception you will get in that. And whenever you want, you can remove it. It is not like permanent.
There's a raise of hand from Dr. Gorakh sir. Since long.
Dr. Gorakh, yes.
He wants to add something.
Okay.
Madam, it was a very nice presentation. And I think what message you have given or what we all must give is we have made abortion not only safe, but easy. And probably we have failed the contraception to make it easy. And that is the main hurdle. And so along with abortion, if we could make it easy, probably as you said, definitely there will be a great acceptance and we all must look towards it. So thank you very much for a very lucid presentation.
Right. You said it well.
We are still struggling for the contraception awareness with the patients. Patients come more frequently for the MTP rather than for the contraception.
Exactly. That's what they're not aware. That's why even pre-abortion counseling as well as post-abortion counseling must have this information about contraception. And since you are not in so much in hurry, I can share many success stories. We have positioned NSV in our pre-abortion counseling as an option, and many of the male partners of our abortion clients have accepted NSV. Our NSV rates are as compared to the other, even in some places, even better than government. So the acceptance of NSV mobilized by our staff is much better than the government, I can say that.
Yeah, Dr. Varsha is actually into doing a lot of training for NSV.
I'm working on it, madam. Yes. Recently, I have started training my gynecologist to go for NSV training, which is a very simple procedure. When I train them, they will start counseling the patient. They will find out the patient. It's like laparoscopy. When you learn and then you find out which is patient for laparoscopy. So I've started this program recently in my jurisdiction because I belongs to Nashik and I have some Adivasi areas where people are, it's not a patriarchal society, I can say. In Adivasi, it's otherwise. So most of the males undergo NSV. We have like 50-50 males undergoing, we have camp like that. So I'm taking my gynecologist there and I've started that program.
Yes, yes.
That is excellent actually.
We also have NSV training program for doctors open to the doctors, non-FPAI, outside doctors, like what Madam mentioned about implants training. We do have NSV training also. 6 of our clinics are training centers authorized by government for laparoscopy trainings, MVA, EVA trainings, IUCD trainings, and now hormonal implants as well as other MMAs. Yes. Any more questions?
Yeah, Dr. Doshi wants to, yes, you can unmute yourself and ask.
Unmute yourself, sir.
Yeah, thank you.
I have
Am I
sent an
audible?
unmute request.
Am I audible now?
Yes, sir.
Yes,
Yes, sir. Yes.
Yeah. It was a very nice presentation, and as very rightly pointed out by Dr. Vashal Hade and Dr. Priya Shinde, NSV has gone out of, I can say, the point, because now we need people who can do NSV. Though I proudly say that I have been practicing obstetrics for the last 27 years, but shamefully I have to say that I haven't seen a vasectomy. And somehow if I convince a patient to do under vasectomy, we don't have a person in and around our place who can do a vasectomy. So the need for training gynecologists for doing vasectomy is also very important, because even if I convince someone for vasectomy, I don't find a person, including me, who can do a vasectomy. So need for training the gynecologist is also very important.
Yeah, I have learned it.
Yes,
So
and she's
I have learned
we
it
have a
myself.
trainer within, so I
Very
think
simple procedure.
we really need
Yeah,
to.
I know.
Next phase, we will have some sessions on training.
Komal has a work now.
Yes.
Yeah.
So we will do that through the Family Welfare Committee, but definitely will require hands-on, and so we'll require people to go to particular centers and do it, because it's a family planning procedure, and it needs to be taken with real precision and with a lot of seriousness. Yes, Madam Ratnamal.
In February,
Madam
last
wants to say
February, we did in Pune, we did a training program for vasectomy, and we did, I think, almost 25 cases. Dr. Kaza was there, and he trained some surgeons, gynecologists. So we had a training. So vasectomy is a very simple procedure.
I know.
It requires a mind to learn it, that's all. The inclination and the time should be there, that's all.
Yeah.
And talking about post-abortal contraception, implant can be inserted at the time when you give her a first tablet of MME. That time only you can insert an implant. And now WHO is talking more and more about self-care abortion. WHO is talking about self-care abortion, where there is no doctor who's going to prescribe the MME tablets, where the woman will take the tablets on her own and cares for herself. What we are worried as gynecologists are always, what if she has an ectopic? What if it is incomplete? Those are fears of a gynecologist and not of the client. And many times they are uncalled for fears, which are the complications are very less.
But they are there.
They are there, but less.
But less.
But I think the gestational age, the duration of pregnancies needs to be confirmed, because sometimes patients, they are really in advanced pregnancy and they resort to methods, and then we get a complication.
No, WHO is not talking about people of living in cities like you and me. WHO is talking of people who are in the remote areas where they cannot go to a gynecologist waiting for an ultrasound. They cannot afford, or they cannot have access to an ultrasound. In such cases, they are promoting in such cases where the clients do not have access to a gynecologist or an ultrasound, WHO is promoting self-care abortion.
Madam, I would like
self-care abortion would be disastrous.
But madam, they are more
Hello.
aware than the city people, like rural.
No, it will not be disastrous. WHO is promoting it strongly. It will not be disastrous. There are very few people who will have this complication.
Women are already using...
WHO, yes, WHO has studied, tried, and put it into practice. It's not going to be a disaster. No.
Madam, I would like to add something.
Yes.
Because I am actually working mainly in the field of abortion care and for safety of abortions and all. But we have seen that definitely in India, it will be a disaster.
Yes.
Though the WHO might have seen all these things, maybe in Africa or maybe in certain countries where these things are not possible,
I think Dr. Gorak has lost it. I would like to complete for Dr. Gorak. I would like to complete for Dr. Gorak.
No, he is there.
Just let me complete. Our women will use it as a method of contraception. And that is a very dangerous thing. To say that it is very easy, to say that it is very safe is very easy. But when it comes to practicality, because even in Rajasthan, we have found out that the easy availability of the pills at Dhobi, the easy availability of the pills of these MTP pills at Dhaba, this will be disastrous. It is not possible for Indian population and for Indian mentality as well. That is in fear, not as a gynecologist, but as a social servant.
Don't you think many people are using medical methods of abortion without prescription on their own. It is going on. It is going on. It is there.
We are treating such cases in periphery day in, day out. I am treating such cases and I found them extremely anemic. I have treating them once in a month, at least one patient I get who is in shock, whose hemoglobin has not been done. She will be bleeding to up to maybe HB6, 7. So a
Yes, yes.
Because I have
You
also
said
very much
MME. What is MME?
and I would even suggest
Medical methods of abortion.
must, and that would be more safe because the life of the woman is not very important. It is more to go for contraception rather than making abortion easily available. Abortion should be available, but it should not be that easily available that people will bypass contraception and go for abortion. It should not be that easily available.
It should be a safe abortion.
Yes,
Whatever
definitely.
we want safe abortion, and the only thing the complication arises when the woman has not consulted and diagnosed whether it's an intrauterine pregnancy or not estimated the correct gestational age. Because even here, like yes, 2 days ago, even I have given 4 blood transfusion to a patient who was a previous to LSCS with taken some pills from outside. So people resort to all these techniques. I don't know for what, when so much is available freely, everywhere, but they still go to some.
All this, it is interesting to listen to the stories of the practicing gynecologists. But at the same time, there is another perspective. You mentioned that from somewhere she took some pills, and we are assuming that she has taken MMA pills. So most of the times, the data that I presented, I did not present a complete data. 1.56 crores of women annually take abortion in India. And out of them, 73% are buying pills from the chemist directly, bypassing any consultation, anything.
Yes.
This is one data set. And another data set tells us that the maternal mortality because of unsafe abortions have come down, especially post 2002. And this is all because of medical abortion. So women are landing up into complications. I'm not denying that, but the severity is definitely going down. And when we are talking about the availability of doctors in real remote areas, it is not possible. It becomes a barrier to make it a criteria to have a doctor prescribing a medicine, which needs to be told to her. Now, Maggie has reached every nook and corner of India. Even Nagaland commercials and those, the borderline villages also, there also we have seen in the commercials that women are using Maggie. And it is pictorial direction that is given how to use Maggie. A woman knows how to use a Maggie. A woman will not, do you think a woman will not take care of her own self if she is given proper information? She will. She will. So let us trust our women a little bit.
This is really a positive attitude.
What you are getting is the clinical side effect of what is going worst.
True.
That is the picture that you can see. A moon, we can
Why
see
not
on
to
the
use
one side of the
contraception,
moon.
madam? If they are very much capable and if they are intelligent, if they can do make a Maggie, then why not to use the contraception? Rather than using the
because of lack of awareness. Because of lack of
no, madam,
awareness.
it is
And many a
because
times
of the easy availability of the tablets, and they don't know
it is the
side
men
effect
who
of that.
decide. It is the men who decide. Do you think women in the family have decision-making powers? Do you think the women go to chemist and buy MMA kits? No, it is their husbands, it is their partners, boyfriends, pimps who are approaching the chemists. We have seen, I've done that study in 3 clinics, remotest of the clinics. They do not, under the name of MMA kit, they get all sorts of chloroquines and paracetamols because it is illegal to store it at a chemist, right? And the chemists really don't want to get into any trouble. They will open up the pills and give it in some paper, they'll wrap it in the paper and give it.
Meanwhile, when it was strict, it was very strict, and now since 1 or 2 years, they are getting the tablets.
The days have gone where the woman is not going and she is not able, the accessible. I think the days have gone. It might be in certain pockets, it might be in certain pockets of the peripheral part of the India or somewhere, but if we consider rest of the India, it is not the case. So I don't think we should use that example for whole of the country.
I think
one thing. I am from Chandrapur. I am from the Chandrapur. I am from the Taluka place, sir. I am in the Bhadravati. I am in the interior, and I am connected with the micro interior. All the patients are very much. They come to the OPD, and they are more obedient than the literate people.
Yes.
Patients. And even in the Gadchiroli, we have 6 to 7 gynecologists are there, and district hospital is very well equipped in the Gadchiroli area.
Yes,
there are less
madam.
of private practice.
Madam wants to say.
Yes,
why
madam.
Not,
Yeah.
why not about the contraception? Why not the district hospitals and etc. Money, if we consider, why not the work of contraception then? So
Yes.
I think one should not use this as a method of easy contraception. That's it. Money, MTP pill should not become a contraception. That is the worry. That's it.
Yeah, I totally agree with all of you that contraception is a first thing. Contraception counseling is the primary thing, and abortion is not a substitute for contraception. Never. Abortion is not a substitute for contraception. Contraception is the primary thing. But if she has an unintended pregnancy, early pregnancy, self-care abortion is the thing which is coming up now, and slowly we'll get adjusted to it. And what complications each one of us are seeing, for every one complication each one of us is seeing, either you may be seeing an ectopic, I may be seeing an incomplete abortion where she's bleeding and her hemoglobin has come down, I have to give her 4 units of transfusion, are much less compared to those women who have taken MMA and got rid of the unwanted pregnancy. What is important is educate them about contraception. That is our primary duty, to educate our women, whether in the city, whether in a metro, whether in the remotest of the places or in the valleys. It is our duty to educate people and see that contraception is available first. But if an unexpected or an unintended pregnancy or an unwanted pregnancy happens, it is our duty to give them safe abortion. But for women for whom a gynecologist, you and me, are not available to them, then they resort to self-care. Thank you so much.
Yes, I think, madam,
time to move on, madam.
What she said, because one in every 1,000 this thing abortions, we take like one complication, and should not be discouraging the use of self-care abortion for the thousands of them who have taken advantage of it. That should be the take-home message, I think.
I would like to ask one question. Slowly we are taking deliveries from home to hospital, and why we are taking the abortion from hospital to home?
Madam is there. All questions are for you, madam.
Wonderful point.
When we know that,
we are ending up with more and more abortions premarital also.
Listen.
It's fine as long as
I can just add on to this.
This is a social question. Let me complete. If you see the MMR, even in that, the out of unsafe abortions, now it is on the hike, right? Though this is not, we can say the absolute verified data, but still they are saying more than 8%. So this is my question, why we are taking...
It was 13, sir. It has come down to 8% now.
Yes.
It was 13 earlier, before the medical abortion.
But I don't think a maximum of the complications are reported because of fear of the criminal and illegal abortion. That is number one.
I don't think so, because you are at the private end, so you would be getting those cases, right?
And maximum
it may not
of
be reported. A woman doesn't have to go and report her complication to anywhere. Except for
time to move on, please, with the AMOC society, with the FPI, sit together and come out with some
have a session.
Yeah, we
solution
will
on that, because both FPI is convinced for the self-medication. And they are convinced with the WHO, but we Amoxian or the Foxian, we have to say something to them. So it's with the president, I think we should move ahead with them.
Yes.
So it's time to move for the panel
Just
discussion.
one point, madam, like I agree, you want to make it accessible. The right of abortion is there for women. But I think when we are making them available, it should come with some instruction or a package like warning signs specifically mentioned, because I think those are really important when there are warning signs mentioned. And
It will.
if patient needs to report to doctor, if
Yes.
the patient
Of
knows
course.
how to
That
do
has.
Maggie and other things,
See,
with warning
self-care.
signs.
Self-care
Yes.
is not
With
yet
some red
legal.
flags. Yes.
Self-care
red
is not
flags.
yet legal in India.
Yes.
It is
So
not
if it
legal
comes in India, it is
If
a
it
point of
comes,
debate.
then
Yes.
we
What
have
we
to
promote is
follow all this.
assisted self-care. We always say assisted self-care because she needs a cushion to fall back on if there is a need. We can't just leave everything to the woman because the health system is unfortunately not that strong, and we have to give that kind of support. So
okay, I think we
love
have
to
had a
continue
nice
this.
discussion. I think the Priya was very right. Further correspondence with the Family Planning Association of India, and AMOGS is there, and we will move ahead. Over to you, Priya.
Yes, ma'am. Thank you.
Thank you so much. I will have to leave for some family commitments. So thank you so much, everybody.
Thank you.
Thank you, ma'am.
Okay, thank you, Shamla ma'am. Thank you.
And sorry for the technical glitch. Never happened.
It's okay, ma'am.
Thank you. Bye.
Our next concern is making MTP safe in case of medical disorders. And the session is panel discussion. And we have dynamic moderator, Dr. Komal Chavan madam, and genius expert, Dr. Gorak Mandrukar sir. So I would like to invite moderator Dr. Komal Chavan madam. We just have seen the CV of the madam and we all know madam very well. Madam, would you like to introduce our panelist?
You can go ahead and introduce.
Okay. Next CV, please. Our expert is Dr. Gorak sir. He's a gold medalist. Sir, is it safe to attend the webinar while driving? Please, I am feeling a little scary. तुम्ही गाडी लावून मला attend करून घ्या ना.
Priya, don't introduce. Just take the names and finish it off.
Yeah,
We are a little bit late. We're quite
finish
late.
up with the slides.
Our panelists are next CV, please. Dr. Varsha Lahade, madam.
Bas.
Madam is
That's
from
all.
Nasik.
Yeah.
She's the president there.
No, don't read. Don't read.
Okay. Thank you.
Next.
Next.
We all know each other.
I am only from the Vidarbha. Dr. Sudesh Doshi sir. Sir is from
Pandharpur.
Pandharpur.
Yes. Next. Dr. Madan Kamble sir, we know sir very well. Welcome, sir. Next. Dr. Abhijit Shingare. Sir is from Ichalkaranji. Welcome, Dr. Abhijit Shingare, sir. Next. Dr. Pratibha Baldava. She is from Tolapur. Okay. Welcome, Pratibha ma'am. Next. Dr. Seema Porwal. She is the President Islampur OBGY Society. Welcome, Dr. Seema madam.
Thank you, ma'am.
Dr. Bharti Abhinkar. Madam is from
Kolhapur.
Yeah. She is from Kolhapur. Welcome, Dr. Bharti madam. And Dr. Kiran Sonwalkar from Satara. Welcome, Dr. Kiran sir.
Thank you.
Yeah, I think you can stop the slide share and I will start my screen sharing. So I think we had a very fantastic discussion today. So many queries and discussion about abortions. We have discussed it in and out from the experts. And is my slide seen?
It's still loading.
It is
No.
Yes.
Yeah.
Make it to full screen.
Yeah, I'm doing it full screen. Is it visible?
Yes, it's
Just
visible, but not
click
full
on it,
screen.
ma'am. Just click on it. Click on the first slide.
Yeah, I'm clicking.
If you
Make
can
it
just
slideshow.
if you can just do it in the slideshow mode, slideshow from beginning. On
Yeah,
the
the
left
beginning
hand side.
option is not coming. 1 minute. I'll just share again. So at the outset, I would like to thank each and everyone who have come here and the discussion, what we did today. Can you see now? My slide, is it
Yes,
seen?
ma'am. Yes,
Yeah.
ma'am.
Yes.
Yeah, so the discussion what we did was really very good. We have representation from all over Maharashtra. I'm so honored to have Dr. Gorak as a panel expert, along with Dr. Varsha Lahade, Dr. Doshi, then Dr. Kiran, Dr. Pratibha, and we have representation from Dr. Kiran, then Dr. Abhijit, and Dr. Bharti. I think Dr. Bharti and Dr. Pratibha had an emergency. They just informed me and they will be joining shortly. MIVC and Dr. Seema Porwal from Islampur. I think really great the representation from all the societies, and I really thank them for joining today this webinar with Family Planning Association of India. And after discussing so much about family planning, we talked and MTP per se and the post-abortal contraception. We have certain times we encounter the MTP in cases of medical disorders, and that is sometimes this is really basic because MTP is done by each and every. So this is a very practical panel. We are just discussing very basic, but we wanted to know the experience of all these esteemed panelists that how to make MTP safe in cases of medical abortion. So Hillary Clinton has said human rights are women's right and women's right are human rights, and making MTP safe is our prime motto, whether it is a low risk patient or a high risk patient. So maternal mortality we just discussed, it is high. Unsafe abortions is always there. And when we talk about the human rights, sexual rights, reproductive rights, it all begins with making MTP safe. So sometimes there are patients having medical disorders, and it can be viewed from the two angle. There can be sometimes medical disorders which are so grave that to the mother, and then they will require an MTP. Or sometimes the patient wants an MTP, and then when the patient comes to you incidentally diagnose a medical disorder, and then you really need to know how to go about. That is a question. Also, the two angle, there are two methods. That is, sometimes we know that the surgical method and the medical method, which was discussed so much in detail, and sometimes some methods fall in a preference. Sometimes you have an high risk patient wherein a patient having some tachycardia or some anxiety related issues, and wherein the medical abortion would not be proper because there may be a lot about bleeding, or maybe the hemoglobin may be low, patient having bleeding disorders. So here you can definitely suggest a surgical abortion in the first hand. And medical abortion, sometimes there are technical, there are some fibroid with pregnancy or obesity and some orthopedic problem where you cannot do positioning, and here you really want to try medical abortion in such patients. So now my question to the panelists, I'll begin with Dr. Varsha. Like, do we investigate all our patients before going MTP? What will be the basic investigation?
Yeah, actually, we do not investigate patients. We take the history. The n number of questions you need to ask. What was her parity? What is her present past history? Any medical disorder? To ask history of epilepsy, history of her previous any illness. So all this history is to be taken before going for any contraceptive, especially any thrombotic event before starting for particular OC pills or hormonal contraceptives. So and basic investigations like hemoglobin and it is there with the patient most of the time.
Yes. So I think you're very right by saying that as per the guidelines from the government website, which shows that we really require to do minimal investigations. Even ultrasound, they have said, is unhelpful. What about ultrasound? Dr. Sudesh, do you want to add something about it? Do you recommend ultrasound for all?
Yes, I would 100% recommend ultrasound for all methods, including medical method of abortion till 20 weeks of abortion. Ultrasound definitely gives you the exact gestational age. Though we are expert in doing PV examination, the newer generation is not that expert in doing the per-vaginal examination and assessing the uterine size. Secondly, ultrasound will definitely show you if there is any adnexal pathology, including ectopic pregnancy. So ultrasound, though not made mandatory by law, clinicians definitely will use ultrasound in only rare settings where ultrasound is not as accessible, not available, then you can think of doing a MTP without ultrasound. But if it is accessible and available, ultrasound is a must. Secondly, about laboratory investigations, I would say rather than doing only hemoglobin, I would go for a complete blood count, because even in the remotest primary health center, now pathology labs are available. They do a hemogram, and in settings when there are dengue epidemics in where we are having low platelet counts, it would be, you would land up in soup if the platelet count is very low without any other symptoms. So not only hemoglobin, hemogram and it is available at every primary health center level. So hemogram, urine for albumin, sugar, blood grouping if it is the patient does not know the blood group, and ultrasound. This should be the basic investigations before posting any patient for either for medical method or for a surgical method.
For medical method of abortion,
Yeah, I want to ask the
ultrasonography.
question. Yeah, Varsha, yeah, you're right.
Yeah,
medical method.
I never, we have to go by per vaginal examination, HB, blood group and urine pregnancy test. We do it for the confirmation. For the surgical method, yes, blood group is needed, urine for albumin and sugar and hemoglobin. These are the basic investigation we do. We do not want any HIV or SBHG or any
No.
Not even a complete blood count. Hemoglobin is enough. HB.
I would go for hemogram.
That is what we do practice in government.
Yeah, this actually is from the government website, but I think in practicality, many people or many OTs, wherever we do surgical abortion, you may like to do the Triple H or the infection panel if you really want to be safe. So this is how the investigations, we just move forward. So now coming, are there any contraindications for medical methods? Dr. Madan, like sometimes when you get a patient and you really with some medical disorders and you really are hesitant to give abortion pills.
As per the history, we have to look for any high risk factors like hypertension, diabetes, or any cardiac disease or asthma. For medical abortion, we use the combination of mifepristone and mifepristone, misoprostol. But asthma is the contraindication for prostaglandins that we have to look for. And regarding anemia, we have to investigate the case and look for any anemia.
Yes. So I think when we talk about medical methods, like these are the contradiction of medical methods which are listed, that is anemia, uncontrolled hypertension, adrenal failure, severe liver or respiratory or renal disorders, uncontrolled seizure disorders, inherited porphyria, glaucoma. So all and allergy to any of this mifepristone or misoprostol or prostaglandin drug, then we need to really consider whether to give medical abortion for this patient. And that is
one thing I would like to add, ma'am.
Yes.
Yes. Misoprostol itself doesn't cause bronchospasm. Though we know that intramuscular prostaglandin, which we use PGF2 alpha, it causes severe bronchospasm. But misoprostol, though being a prostaglandin, it does not act on bronchial muscles. And in patients with asthma, we can use medical method of abortion. Misoprostol is safe for asthmatics.
Yes. We are going to discuss asthma as a case. So we'll just move forward. This was just to have the situation. And these are the special precautions where we have to take during medical abortion. That is whether there is a coagulopathy, heart disease, or an intrauterine device which is already there, women with fibroid, women with scarred uterus, in advanced pregnancy, and women with anti-tuberculosis drug. And misoprostol, it can be used. It is not an absolute contraindication, but at times it is a bronchodilator also. So the caution, that is, it is labeled as a special precaution and not an absolute no. So if it is a well-controlled asthma, I think we can use it. So going to our first case, now I would like to start. This is a Gravida 6. Yes, Dr. Gorak, yes.
The only one thing I would like to add that though it is written on the government website that HB, urine and these things are suffice, there are two things one should keep in mind. Number one is medico and second is legal. When we are going to use anesthesia, then all investigations which are needed for the anesthesia, must be done. Otherwise, later on, if any complication occurs, then the government website or government or any NGO is not going to come there for the support. Number one. Number two, whatever investigations they have given, they have said that these are the minimum investigations
Yes, not MRP.
required. That means these are to be done. Any additional investigations which is needed, that must be done. That should be the message. Second thing, in this era, one should not rely only on HB. Even our Anemia Mukt Bharat guidelines, they say that whenever you want to do of antenatal patient, it is the hemogram. So
Yes.
when we are giving message to the people, it should be very clear cut that ideally all investigations which are necessary as per the case, they are to be done, and minimal investigations required are as per government website 1, 2, 3. Otherwise, later on, same court, same all our colleagues, they are going to take like anything. So message should be very clear enough.
Yes,
Thank
you are absolutely right that we do the minimal which are written, but nobody is preventing us to do the other investigation because there is an anesthesia involved. And I think when we have taken care of these practical things, we are really safe and making MTP also safe. So let's move on to a case. She's a Gravida 3 Para 3 living 3 with Gravida 6 Para 3 living 3 with 2 abortion. She's 9 weeks pregnant and she wants MTP. On examination, you find a pallor, you do a hemoglobin, and a hemoglobin is 6 grams. So Dr. Abhijit, this is to you. What will you do next?
First of all, she's a case of anemia, and she's multi gravida. It means she's gravida 6. So we should not go for this termination immediately. As per, because baseline hemoglobin should be at least more than 10. So we can't do immediately intervention for this case.
Yes, so you have said about 10. Dr. Pratibha, if you are there, what will be your cutoff prior to MTP for medical or surgical abortion? Dr. Pratibha or Dr. Seema?
Madam, increasing the size gestation won't help. Like when the gestation is less, the bleeding will be less, and you go in for surgical method of abortion, and you make sure for cervical priming and use methylargometrine to decrease the bleeding post abortive. And before all that, you counsel the patient for tubal ligation because she's already having 3 lives and she's so pale. You can arrange blood and you have to cover up with antibiotics so that because the infection rate is very much more in these anemic patients.
Yes, I think that is really very correct that we need to offer her MTP, but the main problem becomes that we need to know what are the cutoff because tomorrow it's a medico-legal issue. We don't want to do a tubal ligation or an MTP with a hemoglobin 6. So Dr. Varsha or anybody wants to add, what would be your cutoff when you are going to take this patient for MTP with tubal ligation?
Actually, it should not have any cutoff point. Actually, ideal for surgical interventions, the hemoglobin should be 8.5, so that anesthetist receive at one end, and for 6 hemoglobin, we need to have blood before going for termination, surgical termination. And I don't advise any medical termination for her because she might bleed at home. I don't know, I cannot count the blood loss. And of course, as rightly said Seema, post-abortive contraception is must for her permanent method.
Yes, definitely we agree that we will be doing a surgical method, and here we need to keep blood adequately ready before increasing the gestational age. It will definitely not because she may become a second trimester if we try to wait for her, and then it would be more amount of bleeding. So keeping blood ready and doing this MTP at a higher center is something which is more advisable rather than doing it at smaller nursing homes, so that the patient is safe. So when we talk about anemia, we talk about like the iron deficiency or the nutritional as a more common. And there are certain other conditions also. There is thalassemia or sickle cell anemia. And what about that? Sometimes you have a patient who is having a diagnosed thalassemic patient, and the patient comes for MTP because they are really scared of being having a thalassemic child. So how do we counsel those patients, Dr. Kiran?
Before, if there is anemia, so you have to first patient be physically and mentally stable for doing medical method or surgical method. Regarding the thalassemia minor major, we have to do investigation of both partners, and if they are both are major, then we have to terminate. Before termination, we have to confirm patient is physically fit for termination. If patient is fit, we can go forward medical or surgical method.
Yes. So we really need to know and counsel this patient as to what will be the incidence of carry forwarding the thalassemia. And if the hemoglobin is around 8 grams, this patient requires a proper oxygenation, intensive monitoring of SpO2, vital parameters, so that this patient is stable. And we really need to take good care in a good setup. If it's a first trimester pregnancy, is much safer. If it is a second trimester, we are worried about the blood loss. So we really need to keep blood products all ready. So this is what is given in the guidelines.
In this particular, Komal,
Yeah,
in this
yeah, Varsha,
particular
yes.
case, you need to ask the prior history. How has she delivered and what was the consequences of like postpartum hemorrhage or whatever? Then
Yes.
she had abortions. You need to take the proper history of that abortion, whether spontaneous abortion, whether surgically induced abortion. So out of that history, you can take out what would be the consequences of this abortion. So
Yes.
this is the only way you have to find out. Investigation, yes, thalassemia, as Dr. Kiran has rightly said, both parents has to be investigated, and there are chances, and it is one of the indication for termination, thalassemia. For sickle, I don't think hydration is very important, and the oxygenation. You have to monitor the things.
Yes. Dr. Madan, can you add about bleeding disorders? If this patient, you do a CBC and you do and you find it abnormal. Sometimes you have patients with bleeding disorders also. So in continuation with the hematological disorders, what special care would you take if you diagnose some bleeding disorders?
Regarding the management of this case, actually we have to be ready with anticipating the excess blood loss. We have to be ready with blood products and injection tranexamic acid, vitamin K. We have to keep ready.
Yes, I think we are really wanting to know that a patient should not have a more amount of bleeding. And when we see something abnormal in the bleeding disorder, because we're discussing the hematological at and whole. So here, with an experience, we need to know the severity of the disease. Then with a team of an obstetrician, hematologist, anesthesiologist, we need to find out the coagulation problem, and to use in caution would be our NSAIDs, because they will induce bleeding post-op. So you really need to be really cautious while you use NSAIDs and oxytocin in this drug when we are having certain bleeding disorders, because when we are doing a and medical abortion will be definitely contraindicated here because the bleeding can be unpredictable. So these are the patients where you would take them first for surgical abortion. So let's move on to the next case. We have here a 35-year-old. She's a Gravida 3 Para 2 living 2. She's an 8 weeks period of gestation and she comes for MTP. She has previous 2 LSES, and first was in previous LSES in view of preeclampsia 6 years old, and second was the LSES 3 years ago in view of previous LSES. And now she is a known case of hypertension on TAP, AMLO 5 mg 1 time a day, and she's also on oral hypoglycemic drugs. Her BMI is 28. So now she's come for an MTP in your OPD. This is a first visit. So Dr. Pratibha, are you there? How will you proceed? I can see her, but her video is off. Yes, Dr. Pratibha.
Good evening, everyone. She is a Gravida 3 Para 2 living 2 with 8-week pregnancy, and she wants an MTP. She's a case of previous to LACS, and she has preeclampsia and diabetes. I would take a physician reference first to control her diabetes. And because she's previous to LACS, and she's 8 weeks, it is better to go for a surgical MTP rather than a medical MTP.
Yes, and what will be the investigations?
I would first do a fasting postprandial and HbA1c to see her diabetic status. I would do a complete LFT profile along with CBC, BTCT, and a PT, APTT to know her preeclampsia status, to know whether she can go, she can have high risk of bleeding or complications of preeclampsia, and then advise her a surgical DNC.
Yes. Dr. Sudesh, you want to add anything?
Hello.
Yes.
Yeah, what I would like to add on is that while doing any surgical abortions, I would mention importance of priming with either tablet misoprostol or whatever you like it. Tablet misoprostol 400 micrograms, either 4 hours prior orally or vaginally. Priming makes surgical abortions very safe. The dilator part on my OT theater, OT table is gone. I don't require any dilators at all now, because it literally, the sauce is open and you can just remove. So the dilatation part, the perforation part is gone. So while doing any surgical abortion, priming with tablet misoprostol 400 micrograms, either orally or vaginally, is very, very important.
Yeah, regarding her investigations, she is on oral hypoglycemic. So the blood sugar is very important. The hypertension, for hypertension, we need to check the blood pressure. We have to do ECG if it is required for her. Her BMI is very high. Before going ahead for surgical termination, and preferably in previous 2 LSCs, we should go for surgical termination. So that is my take, and you have to ask her to go for either permanent sterilization or she can use a COPD.
Yes, I think
post-abortal contraception.
Yes, you have highlighted very well that we need to sometimes, because of the age constraint, because of the high risk factor and the BMI, and ECG is something which will be really important. And we need to even think about doing a tubal ligation for this patient. Dr. Seema has raised her hand. Please add.
Madam, I don't agree with surgical termination because she's diabetic and the chances of infection are a lot. So I think 8 weeks you can go for a medical termination if the blood pressure is controlled.
Yes, actually,
because CAR is not a contraindication to medical termination.
None of the, not even the preeclampsia, not even the diabetes, not even the obesity, not even the previous, nothing is contraindication for medical abortion.
Medical termination, and medical termination is a better option because she's diabetic and she can have infection because of intervention. And her BMI is also more, so I think medical will be a better option than surgery.
If she aborts completely, then it is safer. Otherwise, you will have it.
Yes. So you need to individualize this case, because that is the reason there are so many other high risk factors.
Most of the time it is incomplete.
Yeah. And
when it is incomplete, you can again repeat after I think 15 days a misoprostol.
Yes.
According to book.
Dr. Madan, do you want to add anything? What would be your choice?
Shall
Because
I
we
add
like in panel, the discussion. Yes, Dr. Gorakh, I was waiting for you. Yes.
Actually, because this is a previous 2 cesarean section patient, so I think ultrasonography guided surgical abortion after the priming with the misoprostol will be the correct and great option under a good antibiotic coverage. So I think that will be the option under good antibiotic cover ultrasonography guided surgical abortion. That is the answer. Anybody can comment on it.
Yes.
To avoid medical legal problems, surgical one is best.
Yes.
One
Just
more
a-
thing we can do.
Just a minute, madam. There's a reminder from Sagnik that we have to wind up by 8:30.
Yeah, we'll finish. Don't worry.
One more thing which I would like to add, we can have a middle path regimen, something like that. What we are told is we can induce a medical abortion, but what you do is you give misoprostol, and the day of misoprostol, you can admit the patient, give her misoprostol under observation, keep her for the whole day, and if required, be ready for surgical evacuation and then discharge the patient. So this way we can have the advantage of medical abortion also and have a safeguard of surgical abortion also.
Very safe approach.
Yes. So safety first is very important,
Yes,
and we
yes,
really need to know, because this patient is just on the zone that you need to take a decision whether to do medically or surgically. But what is most important is the patient safety. And then when we know that the patient, really we need to work up this patient, or the blood pressure is not controlled, or her sugar levels are not controlled, and she may take time for the workup. So I think the surgical, we need to investigate her on the guidelines of surgical abortion. And if everything looks okay, we can try medical, giving her medications, but that also under admission and under close supervision. That point is very well taken. And I think I will not go into detail of this, because I think all panelists have said this is the same synopsis of everything, that if you take them for surgery, the morning dose of antihypertensive need to be taken, proper control of BP need to be done, and these are the cutoffs, and the ergot drugs to be avoided in such patients. Diabetes also, per se, we need to monitor post-operative the blood sugar levels also. And if it is a day procedure and it's a well-controlled diabetes, then when the patient resumes her diet or something, we can start the dose of anti-diabetic, and antibiotic coverage is must. So this is how the schedule is given. And obesity is a difficulty. So in only obese patient in early pregnancy, I think medical is something which is more important. And regarding the contraceptive, I'm not going into the post-abortal contraceptive part, because that was also the part of the discussion, because we had a detailed discussion on it. So let's, if this patient wants tubal ligation, now I just want your expert comment, because she has multiple high risk factor. Are investigations sufficient, or we need to do something extra care for doing a tubal ligation?
Tubal ligation, yes, for the surgery, for anesthesia, fitness, whatever you require, you do it. But in this patient, I would like, if she wants a permanent one, I would go for laparoscopic tubal ligation. It is the best. I'm presently doing laparoscopic camp all over Maharashtra, almost Nagar, Jalgaon. I'm getting 50% of patients of previous LACS for tubal ligation. So it's the best method rather than opening.
What about the consensus of the panel for tubal ligation?
I would counsel her husband to go for vasectomy, or rather than going her for tubal ligation, I would advise her to go for intrauterine contraceptive device.
Yes.
If she comes under guidelines given for tubal ligation, we can go forward. Else, to avoid tubal ligation in such a patient, because there are other complications of tubal ligation due to obesity, hypertension, diabetes mellitus, we can advise other contraception. Now, currently, the termination of pregnancy is important rather than the tubal ligation.
Yes.
Yes. Dr. Seema, your take on it?
Yes, ma'am. If permanent sterilization is required, laparoscopic will be the best. And we will advise vasectomy, prefer vasectomy at counseling about the risk to the patient.
Yes. Dr. Abhijit, I think I want to take the view, because we require different opinion, because what happens, we come into dilemma sometimes when patient really wants tubal ligation, and we have to counsel her, that we would do this and that. It is sometimes it is like we really have to counsel, you have to do family planning. Sometimes patient is strongly willing, and then you are saying that she is not medically fit. So that is what I wanted from the panelists. So Dr. Abhijit, your take on it?
I'm agree with Dr. Seema, madam. It should be, if it is permanent sterilization, we have to go for laparoscopy, and better we counsel her not to go for vasectomy.
Yeah, and Dr. Pratibha and then Dr. Gorak. I want the expert comment at the end. Dr. Pratibha, are you there? Or Dr. Gorak, you can take it. Kindly unmute, sir.
Yes. Actually, I will go with the panel as they have said very rightly. Only thing we have to use your utmost things for the counseling of such patient. We have to tell him what are the problems she is going to face if she becomes pregnant later on. And then we have to give her, you have only two options, either to go for the laparoscopic tubal ligation or vasectomy. What is best? What do you want to choose? Mane, I think as madam was saying, we have to give capillary approach, but again in that, but दो option दे दो कि या तो मटन खाओ या तो चिकन खाओ, वो वेज का option ही मत दो.
Correct, correct.
Because if you go like that, probably she will be the best. That should be the counseling, I think.
We could go with the tagline, जो बीवी से सचमुच करे प्यार वो वासेक्टोमी से कैसे करे इनकार.
I think it is a
Yeah,
great
it is
tagline.
very easy to say this. Sudesh, it is very difficult to counsel. The lady only says, Madam, unka kuch karo nahi, mera hi karo jo karna hai. That is what she says. She never gives the consent for vasectomy. So counseling is really difficult. But ideal is vasectomy. As I agree with Dr. Sudesh. And as I talked, I said about the cafeteria, whatever you tell them in front when they're sitting, but they will ask you, Madam, you only tell me what is good for me. So at the end, you have to give her proper advice. You have to counsel her.
See, when they come for IVF, I will give you example another way. When they come for IVF with lots of complications, then we will do anything, whatever we want. But when they come for tubectomy, and at that time, we will think, "Arey, ye complication, wo complication,
that's true.
uska diabetes." But when they are coming for IVF, सब चलता है. When they are coming for IVF, हमारा done से, they will eat the estrogen in the packets or in the tons. But when it comes to the OC pill, we will think कि अरे इसका contraception, इसका वो क्या वो इधर उधर का
Vein thrombosis, embolism, thrombosis.
Yeah. That means they are infertility is their unmet need, not the contraception.
Not contraception. I think that is real important message.
That we should not be unbiased while discussing with the contraception.
Okay.
And while discussing with the other thing. I think that is the message.
Yes, I think we'll just move forward. This was a great discussion. Now we have a 20-year-old. She's a primary gravida and she's come at 10 weeks of gestation. She has history of dyspnea, exertion, occasional epistaxis, hemostasis in the last, like she's having since a long time. And she is a known case of cardiac problem. She has an echo report, which is showing a large non-restrictive perimembranous VSD with balanced shunt and significant pulmonary artery hypertension. So now when such a patient comes, should we advise MTP? That is the first question which will come. And I think we can ask Dr. Seema.
Yes, ma'am. Because pulmonary hypertension itself is a strong indication for MTP.
So I think everybody in the panel is agreeing for MTP.
Yes. Very high mortality.
Yes, high mortality. And so pulmonary hypertension, but there are certain other cardiac conditions which you will actually advise MTP. And Dr. Madan, can you just enumerate those?
Yes, heart failure with more than grade 4, again severe metabolic disorders like diabetes, hypertension, uncontrolled, frequent attacks of angina, aggravated cyanosis, or a primary more than 35 age with heart disease, severe MS, etc. Such cases are contraindicated.
Yes, so these are the WHO risk class 4, which are contraindications to pregnancy and pulmonary arterial hypertension of any cause with severe systemic ventricular dysfunction when the left ventricular ejection fraction is less than 30%, previous peripartum cardiomyopathy, severe MS, aortic stenosis, Marfan's or aortic dilatation more than 50 mm. So all these are actually contraindications for pregnancy, and they become an indication to not to prolong pregnancy, because as the pregnancy prolongs, the risk and the load on the heart will going to increase, and then patient will really have problem. And coarctation of aorta is also one of the absolute contraindication for pregnancy. So now this patient was advised to terminate, but she refused because she was a primary gravida. We advised her all consultation, everything, but she refused. Now she has come back at 18 weeks of pregnancy. And here she is having an ultrasound showing 18 weeks, 3 days, and the period of amenorrhea is 19 weeks, 5 days, no congenital anomaly. So should MTP be advised at this point? Dr. Sudesh, Dr. Varsha, Dr. Madan, anybody can take.
Yes, we can advise MTP now
She should
also.
be advised.
Yes.
MTP can be advised, and MTP is advisable because she has so many problems at 18 weeks, and it is going to worsen more as the pregnancy advances. So if she says you can go ahead with MTP, second trimester medical legal.
Dr. Gorak, yes, I want your opinion on this.
Right.
We are
Here
short of
at
time.
this
Yes.
Here at this stage, we will again have a meeting with a physician, cardiologist, anesthesiologist, patient, and her relatives.
Yes.
What we do at our place, and we literally do a meeting. In
Yes,
that,
ma'am.
से बताना है, या तो माँ को बचा सकते हैं, नहीं तो बच्चे को बचा सकते हैं. That happens only in the film. It is always the mother.
Yes.
So first priority is given to the mother.
We have to perform this with the great backup of ICU.
Hello?
Yes,
ICU
yes.
backup will be there, yes.
These are the reasons. And here again, there is a chance that you can undergo termination by the law. So the chance should be given. And if she doesn't listen, I don't think then a promissory note should be taken from them. However, they are not listening despite of giving them the chance of her life survival.
Yes, agree with you that this patient was of Eisenmenger syndrome, and here really, as the pregnancy advances, there is going to be severe maternal compromise, and at any time, given time, and MTP can be advised if patient is in the legal age of doing MTP for maternal benefits. I think we need to wind up because I think we have really short of time. And we need to take care about certain drugs, that is ergometrin, prostaglandin, because it has this potent vasoconstrictive effect. And wherever we are doing this needs to be done in a tertiary center. And anticoagulants also needs to be used caution, because I had this question on this. So really we need to be careful because anticoagulant can predispose bleeding. So medical abortion here is definitely not recommended. This asthma, I think we have discussed over the course, so I'm not going to go. And I will just come with a summary. This is a summary which I prepared, and this is from the government guidelines, wherein wherever they have said the hemoglobin less than 7 should be done at higher centers. Heart disease definitely at appropriate higher centers. Asthma, if it is there, PGE1 analog should be used in the case of post-abortal atony, excessive bleeding for cervical priming, and women should be stable and should not have any acute asthmatic attacks. So we really can use our prostaglandins if patient is stable. And a bleeding disorder, if there is there, patient will require blood transfusion. So any hematological problem, you see if that you have a functioning blood bank available. And in diabetes, the high blood glucose levels are not dangerous, but you need to be very clear about the ketoacidosis, which should not be happening. And insulin dose probably does not require if it is done under a short sedation. And the technique which we have discussed, that giving them ripening the cervix and then doing it under light sedation will definitely have no need of this oral or insulin being given. If there is an hypertension, you require to give oxytocic injection. We need to be really careful about the ergometrin. And in seizure disorder, patient can take the usual dose of anti-seizure medicine on the day of the abortion, and we can actually continue it. There is not much of contraindication. Same applies for the thyroid and for the renal disorders, where patient can be evaluated and done at a higher facility. So this is a conclusion that any pregnant woman can have medical disorders not previously diagnosed or can be incidental. Wisdom lies in correctly understanding the disease, its problem, treatment, and what medications to be avoided. Effective post-abortal care for women with medical problems with reduced pregnancy-associated morbidity and mortality, and hospital-based abortion is recommended for women with medical abortions. So these are the references, and I will just end. This is my vote appeal. I think everybody has said for me, and I sincerely with folded hands, request all of you to support me, my candidature for Vice President Foxy from West Zone. Thank you so much.
Thank you.
I think I was on time. The team.
Yes.
Thank you so much, Komal.
Thank
Very
you. Thank you.
interesting and nice.
I had to discuss a lot,
Nice
but I
moderation.
think we had today President from Family Planning Association, Dr. Ratnamala, and I think your the time what we asked you the questions, they were more enlightening to us, and we really had a great time with Family Planning Association of India. So
now I think we should hands have we already we are working together, but with PHFI we all should with the Family Planning Association of India should more and more work towards the making easy the contraception, and how we should learn from them how we can make it very easy available for our patients. So Madam Desai Madam, it is a sincere request that because now Komal is there as a chairperson of the AMOGs at Maharashtra level, so we can take this task and she is very much able to take this task ahead. So thank you very much for coming here, Madam. Thank you so much.
thank you.
Yes,
We are
ma'am.
looking forward for future associations also, and
We
there
all
is a
are
series of
looking.
webinar with FPAI. So this is not the end. We are going to see more of you and learn more from you.
Thank you.
Dr.
Thank you. It's my pleasure. It's my
Dr.
pleasure.
Gorak, safe contraception, safe abortion, and safe driving is also important. Please drive safely.
Travel, I know. That's what I was going to say.
Right.
He is on road.
The last message I would like to give all of you is that please make abortion safe. Don't make it easy, but please make contraception safe as well as easy. That is the message.
Yes, definitely. I agree with you.
Thank you. Good night. Bye bye.
Good night. Yeah, Monica, you can go ahead for the vote of thanks.
We thank each and every faculty who has been a part of this webinar. Dr. Ratnamala ma'am, Dr. Shamla ma'am, Dr. Gorak sir for being an expert panelist, Dr. Komal ma'am for being a moderator for the panel discussion. I would like to thank all the panelists and the delegates who have joined for this webinar. Last but not the least, I would like to thank all the associations who have been a part of this webinar, including AMOX, Foxy, the FPAI, and TSC Foxy also. Thank you so much, ClearNet, for being an academic partner for this webinar. Thank you, Komal ma'am, for the excellent association, waiting to learn more from your side, ma'am. Thank you so much, ma'am.
Thank you.
Thank you, Monica. Thank you,
Monica,
ClearNet
for the
team.
wonderful
Ma'am, and we definitely
ma'am.
hold a training, online training for at least all Amoxians, if not for all Foxy,
For
ma'am,
sure,
under
yes.
TSC and MTP committee, ma'am.
We are looking
Yes.
forward.
We are looking
Thank you.
forward. We will join hands. Varsha is of medical legal committee. I think we will join forward and we will develop a module. And I think let's have more practical
Practical
approaches in the
training
next
sessions,
couple.
ma'am, definitely, ma'am.
Yes.
Even for vasectomy, we have Dr. Vandana Gandhi, madam, who is also doing a lot of work with vasectomy advocacy, ma'am. But the problem is that the moment you utter the word, the patient is not in your OPD anymore.
So let's have now sessions on the newer contraception. The next program, I think that will be more, and we will really looking forward, and also vasectomy also. I think that is something which is the more interest which has developed in all of us, and I think we need to take it at a next level.
Next level, ma'am.
Yes.
Sure, ma'am.
Thank you so much. Thank you, Dr.
so
Gorak.
much.
It was very nice of you. Have a safe drive. I'm also worried about it now. Yeah. Chalo, bye.
Chalo, bye-bye.
Thank you.
Thank you, everyone.
Thank
Thank you, everyone.
Bye-bye. Take care.
He's on the driver's seat, so that I'm very much safe now.
Okay, good.
Let
We
us see
hope
you tomorrow, Gorak. See you.
Yes.
we hope to see all of you again with another
Thank you.
topic.
Thank you, Sagnik.
Thank you.
Thank you. Welcome. So as of now, we are ending this session.